our TrueFem community. Once again, I have the pleasure of having Dr. Margo Anderson here. Today, we're going to be talking about a pretty common diagnosis called Polycystic Ovarian Syndrome, or PCOS. And I know some women in our TrueFem community, or women that have reached out to me, have encountered this in their reproductive health. So we're going to dive a little bit deep into it today with some questions from the expert herself, Dr. Margo. So it's been a little while since she's been with me, so I'm just going to introduce you guys once again to Dr. Margo and give you a little bit of background about her. So Dr. Anderson is a board-certified family medicine physician who is currently providing direct primary care near New Orleans, Louisiana. And as a direct primary care physician, she works with patients in person and via telehealth in an intimate way that allows for an ongoing relationship with patients and individualized care solutions. Dr. Anderson has a special interest in preventing or reversing disease through lifestyle and completed the Integrative Medicine Residency Program through the University of Arizona. She has a particular passion for caring for women with a focus on hormones and fertility, and is a certified NAPRO medical consultant. So obviously, we are going to learn a lot from Dr. Margo today. So thanks for being here and sharing your wisdom with us again.
Thank you. Thanks for the introduction, and it's always great to speak with you.
Yeah, so today we're talking about PCOS. Like I said, a lot of women are impacted by this or have symptoms of it and don't realize it. And PCOS, as I mentioned, stands for Polycystic Ovarian Syndrome. And the name can be somewhat misleading for a few reasons. Can you describe what PCOS is and the criteria you use for diagnosis for it?
Yeah, so PCOS, as you said, Polycystic Ovarian Syndrome, it's a disorder of the endocrine system, so meaning the hormonal system, but it does have whole body effects. A lot of people think it's just like a reproductive disorder, but it really is the endocrine system affects the whole body, and so does PCOS. Whenever we use the word syndrome in medicine, what that indicates is it's a grouping of symptoms. So it's not like for example, in diabetes, you just can do one blood test and say you have diabetes. But whereas PCOS, there's not one test that says, boom, you have PCOS. It's this grouping of symptoms that we put enough of these things together and you have the syndrome. So to be diagnosed, there are 3 criteria, and if you meet 2 of the criteria, we can say that you have PCOS. Those are having either clinical or biochemical hyperandrogenism. So what that means is clinically, like we see it with your outward appearance or some of the symptoms that you have, or biochemical means we see it on blood test. And then hyperandrogen, those are the male type hormones like testosterone, and you'll see the levels are high. Some of those clinical signs that I talked about are hirsutism, so having male pattern hair growth in a female, like having a mustache or hair around the nipples or hair on your abdomen, or having hair loss on your head, maybe in a male, what you'd see like when a guy loses some of his hair. Having severe acne, those are some of the signs that have to do with having those high androgens. The second criteria is irregular menstrual cycles, so not having that typical 28 to 35 day cycle. Usually in PCOS, the woman is having very long, like up to, going 90 days, a long cycle or something. And then the third criteria is seeing polycystic ovaries on ultrasound. So those are all things that we're looking at. There are other things that we can see that frequently go along with PCOS. One of the big ones is insulin resistance, which is a problem with handling the blood sugar and can lead to diabetes in some people. And so that's a common side, but it's not one of the criteria.
Mm-hmm. Yeah, that's really interesting. So, young teens, obviously, who are starting their period, it might be a while before diagnosed with something like this, but what kinds of things might appear in puberty when somebody starts cycling? Like what kind of symptoms might a young woman might experience, and the severity of those symptoms?
Yeah, so For the first, maybe say around 1 to 3 years of a girl's cycle, when she first starts her period, it's completely normal to skip periods, to have those longer cycles actually, because your reproductive system is still maturing at that point. But after that period of time, if you find that they're still long, you never kind of finally normalize into that monthly cycle, that's one of the more common symptoms. Is you just, all your friends, they're seeing, oh, my period comes once a month, and you're like, I have no idea, mine just comes when it wants to come. I hear girls use those terms. The other thing you might notice as a young girl is if you do have the high androgens, like high testosterone, you might notice some of those abnormal hair growth or having really severe acne. So just some of those symptoms we talked about. And then with the insulin resistance, you may find that you're either gaining weight abnormally, having trouble maintaining a healthy weight, or the other thing that can occur with insulin resistance is having this skin change where you have some brown patches like under your arms, your neck, your upper thighs. So those are some of the symptoms you might notice. PCOS also does run in families, so it's helpful to ask your mom, your sisters, your aunts, what their cycles are like, and also make sure they know what a normal cycle is, because you might say, oh, my period only comes every 3 months, and your mom might say, yeah, that's how mine was too, and then the problem gets missed.
Yeah, totally. Well, you kind of touched on keeping track of your cycle, right? And I think a lot of times when young teens go to a doctor's office and they kind of express some of this, maybe later on in the teen years, not very many of them are probably charting their cycle at that point. We always say it's great that you keep track of your period, right? But then there's a lot of other data that happens in between one period to the next when you're actually learning a way to standardize and chart your cycle. So for a woman who is charting and keeping track of her biomarkers and her cycles and whatnot, how might a PCOS pattern look in her chart?
So the most common thing we see, we've already talked about a lot, is the long period. So going, a normal length would be somewhere 28 to 35 days-ish for each cycle. So if you're someone that goes beyond 35 days before your next period comes, in some cases 50, 60, up to 90 days, we see that in the charting. Some of the other things we see that is separate from just when you bleed, when you're on your period, we can pick up on charting when someone is, we call it anovulatory, meaning they're not ovulating, or they're not having a healthy, maybe it's sort of a subpar ovulation. So some of the signs we see on charting are in the post-peak phase, so the second half of the cycle after ovulation. It might not be an appropriate length. You may, a lot of the charting, like if you're doing the charting that you measure your temperature, you may not see the temperature rise like it's supposed to because you don't have the progesterone rise that comes after ovulation. Some of the other things that I commonly see in some of my patients is lots of continuous mucus, or a mucus pattern that doesn't fit into the way it should normally fit, kind of more random mucus, which can, in those patients, they get frustrated because they can't identify when their ovulation is. And it's because the ovulation isn't really happening in a healthy way because they have PCOS. And so it's frustrating because it's not a normal chart, but that right there tells us, okay, this is not a normal chart. What are we going to look at and do to try to fix it?
Yeah, there's so many clues that come out with charting. And that's, again, I think, shameless plug for why people should be charting their cycles is just, not only just PCOS, but so many other things can be discovered. And women who I work with who are charters have such a fine-tuned understanding on a day-to-day basis of those changes, right? And they can have that education, so it alerts them when something's not right, which is really
Right.
valuable because then they come to you and that treatment path gets started. So I think that's really helpful. I have a question here. I know this could just be a little bit of a wormhole. So, you know, you can keep it kind of more the 10,000 foot view. But commonly when girls go into their providers when they're young or even later in life, birth control is the #1 prescribed treatment for PCOS. So the question is, does this actually help the underlying problem, and why or why not?
Yeah. The short answer is no, it does not help the underlying problem. But like you said, yeah, this is a question could take a whole lecture in itself to answer, just because you'd have to go back and look at the actual physiology of how birth control works and what it's doing to your cycle. And you're right in saying that, you know, that is, you know, if a woman is not trying to get pregnant and she has PCOS, her cycles are irregular, the treatment of choice is birth control. There's one very important reason for that. One of the things that you're at risk for if you have PCOS is endometrial hyperplasia, or endometrial, which could turn into cancer, which is cancer of the uterus. The reason is because you're supposed to have that monthly bleeding, that monthly period, to lose the inside, you know, clean out the inside of your uterus, and then it regenerates again each month. If you don't have that monthly cycle, you're one of those people that goes 90 days before they bleed again. That's a lot of days for the uterine lining to get very thick. And so when you take birth control, it forces the uterine lining. One of the things it does is it thins out the uterine lining. And then it also, if you're on the type where you do bleed every month, it's another way it thins out. So it's a protection against endometrial cancer. With restorative reproductive medicine, we approach that from a different way. We can help the woman that is not having a monthly cycle. We can help her get to that cycle to where she wouldn't, you know, also reducing the risk of endometrial cancer. But that's one of the things where if you have PCOS and you're not taking birth control, you still need to do something about that if you're not having a monthly cycle because of that risk. The only other thing that birth control does that can be beneficial for the symptoms of PCOS is it does lower androgen levels. So that's why some women that get on birth control do see that the hair growth issue gets better or their acne gets better. That's also why birth control causes low libido in a lot of women, is because of lowering the androgen levels. So I just wanted to touch on those things because those are things women will hear in the doctor's office, you know, why birth control is important for PCOS. But like I said earlier, it does nothing to fix the underlying problem. Once you stop the birth control, if you're trying to get pregnant, a lot of times there's going to be an issue, and then you're going to go through that struggle potentially with infertility. PCOS also puts you at higher risk for miscarriage, gestational diabetes, gestational hypertension, you know, high blood pressure in pregnancy, other complications. So, you know, when you take that birth control, you're just covering up your PCOS, kind of putting it into a box, forgetting about it, while the underlying issue that's causing your PCOS is still going on there. And then you put yourself at more risk for these things that are still going on. So, like I said, putting you at higher risk for these potential pregnancy complications. But then the other things, as I mentioned earlier, that PCOS is sort of a whole body disorder because of this disorder of the endocrine system and how frequently PCOS goes hand in hand with insulin resistance. These women are at higher risk for diabetes, and they are at higher risk for heart disease. So when you're taking birth control and you're just suppressing some of the symptoms of PCOS, but you're doing nothing to heal that insulin resistance and that metabolic abnormality, you're doing nothing to say, how am I going to reduce my risk of diabetes? How am I, you know, not only that, but birth control itself actually raises your risk, you know, kind of worsens insulin resistance. And you know, so it's sort of like you get yourself into this hole that you're not addressing the real problem. A lot of times too, women, you know, they go to their doctor, they don't even have the diagnosis of PCOS. They just go in and they say, I'm having irregular cycles. My acne is out of control. You know, I have the abnormal hair growth, you know, these symptoms that come along with it, and they don't get anything other than, okay, take this birth control, it'll make it better. And then those women don't even get a diagnosis. They don't even know they have PCOS because they take birth control, their symptoms get better, but then they, you know, they don't find out what's really going on.
Yeah. Well, it's kind of interesting. I think one of these like groundbreaking truths that you learn when you enter into this world of restorative medicine is that ovulation is a sign of health. And restoring ovulation and restoring a dysfunctional ovulation restores a lot of other imbalances that come with that, right? Like lack of ovulation equates to lack of proper levels of hormones that you need to feel good from head to toe. And so when that's out of whack, everything's out of whack. So I think, you know, correct me if I'm wrong, but really the goal of this restorative approach is to restore ovulation, restore your body back to that natural cycling with the fluctuations in hormones, and to get to that root cause versus, like you said, treating symptoms and allowing whatever it is underneath to continue, you know, unchecked. It's just a whole different way of approaching medicine. It really is. And I don't know if you feel this way, but a lot of practitioners I've talked to feel like detectives when you don't use birth control as your only option. Like now you have to be a detective and get in there and actually figure out which tools you need to use to help solve the issue.
No, like you said, restoring that healthy ovulation. That's exactly what we're after, because the ovulation does produce the hormones, and you know, you have receptors for those hormones all over your body. It's not just your uterus. It's not just your ovaries. You know, it's you know, things like building strong bones, your brain function, you know, all of that. So
yeah, totally. If you take away anything, I hope people know ovulation is a sign of health. So the big takeaway. So in your world, Dr. Margo, what type of testing or follow-up is recommended from a restorative approach that's different from the traditional medical model?
Yeah, so one of the first things that we do is obviously look at the chart. You know, the chart, it's our guidepost on which we base everything else, because it gives us a window into what the hormones are doing, gives us some clues. Is there a good ovulation happening? And then from that point, particularly for the estrogen and progesterone levels, we're doing targeted testing for where you are in your cycle, what your hormones should ideally be. So that's one of the different things we do within the world of NAPRO and restorative reproductive medicine is because we have a chart as a guidepost, we're able to tell when you know, hormone levels should be certain things. Apart from that, I do a very thorough workup for looking at all the androgen levels, looking at the idea of insulin resistance, and if you have that, you know, what's your blood sugar, what's your insulin, what's your, you know, how does your body handle that, and then checking the full thyroid panel is very important. We see thyroid disorders often running along with PCOS, and like I mentioned earlier, because these women are at higher risk for metabolic disease, including the diabetes, the heart disease, you know, we're kind of taking all that into account as part of our treatment. Another thing that is different than the traditional approach is sometimes we do follicular tracking ultrasound. So that's where we take a woman, and we have to have the chart once again to do this, because we're trying to pinpoint when, based on her charting, when she's ovulating, we're doing a series of ultrasounds during that time of the month. So it's a little bit intense because she has to come in several days in a row, and we're doing an ultrasound to look at the ovaries to visualize the developing follicle that then becomes a dominant egg that ovulates. And then with women that have PCOS, we can see with that ultrasound, you know, in real time, is the follicle developing to an appropriate size? is the ovulation happening in a healthy way that it's supposed to happen? And we can potentially pick up some problems there, which then can be treated more specifically, you know, to what is going on in her. Because with the charting, you know, looking at, when we chart, you know, we look at cervical mucus, some people use temperature, some people use the ovulation strips that you pee on, you know, all of those things. Those are all indicators of ovulation, but they're not absolute confirmation. It's the ultrasound that absolutely confirms, you know, because we see, there it is, so you ovulated. So that's a useful tool in some cases.
Yeah. Well, it's interesting. Just your description of that treatment path, you know, if there's people watching this that have been diagnosed with PCOS, I think it's encouraging to know that there are ways to get to the root cause, right? And also, not only that, just to know that you have it, but then also pursue possible restorative treatment, right? Instead of feeling married to birth control for the rest of your reproductive years or whatnot. So that explanation in and of itself was like really helpful, I think, even for me, because as a patient, you know, for those people listening, like I said, PCOS, you're going to have a very intimate relationship with a restorative reproductive doctor or provider of some sort, because they're going to get to the bottom of it. It might take a minute, but they're going to get there. So yeah, I just think that's encouraging to know that obviously that's how intricately you work with your patients to get to the bottom of this. So that's pretty cool. And I guess my last question for you, Dr. Margo, is what do you recommend women who suspect PCOS or some kind of disturbance, metabolic disturbance, what would you encourage them to do to pursue treatment? And are there any resources that you would share for them? Share with them.
Sure, yeah. Yeah, I mean, number one, chart your cycle. You know, that learning how to chart gives you the you know, kind of the starting point of the information of what's going on. And then finding a doctor who is going to diagnose and treat you with this restorative approach, who's going to listen to you, work with you, kind of be on your team, you know, find a doctor that knows how to read your chart and treat you in that way. And then because PCOS is so intertwined with insulin resistance often, and then the high androgen levels, there's a huge lifestyle component to the management of this disease. And so for some women, you know, they need to be working with a nutritionist or some sort of health coach. That can be extremely beneficial because it just has an enormous role in that restorative, you know, restoring healthy ovulation. You know, as far as resources, there's so many things to look at. I actually did a book that had been on my list for a while, PCOS SOS by Felice Gersh. She's an integrative doctor that she doesn't do the same exact restorative reproductive medicine or NAPRO or any of these things, but she does treat PCOS from an integrative, kind of more restoring health standpoint. And she had some really good insights, you know, in her book that I'd recommend to anybody that has PCOS.
I'll put that in the show notes so people can access that. And every time at the end, I tell listeners to go to your blog, because Dr. Margo has a blog where she writes lots of great content and education, and it's drmargoanderson.com, right?
Yeah, that's correct.
Okay, and I'm going to go ahead and post that in the show notes too. So if you guys have questions or whatnot, obviously, if you're watching this video and you're not part of our TrueFem community, you should join, because Dr. Margo's in there and we have opportunities to get some of your questions answered if possible. And is there anything else that we can do to follow you, Dr. Margo? I know you have an Instagram handle as well. Dr. Margo, is that right, on Instagram as well?
Yeah, it's Dr. Margo Anderson,
okay.
Yeah.
So y'all should follow her. She posts great stuff, and we're just so grateful that you spend the time with us to educate us on lots of different topics. This is one of 3 videos we've done together. So if our viewers haven't seen the other ones, then you ought to just keep going on the queue here and keep watching so you can learn some more. So again, thanks for being with us, and we'll have some more excitement for women in the months to come. Thanks, Dr. Margo.
Thank you.